Hi friends, I welcome you all for this session. Today's topic is about Placenta Accreta Spectrum. Placenta Accreta Spectrum refers to abnormal adherence of placenta to the uterine wall. Normally, the placenta separates spontaneously after delivery, but in past it fails to do so, and so attempts at removal causes severe hemorrhage. They are classified into three forms based on the extent of invasion. The placenta accreta is where the villi attaches abnormally to the myometrium, whereas in Increta it invades deeply into the muscle. And in Percreta they penetrate through the uterine serosa, sometimes involving adjacent organs like bladder. Because the placenta invades into the myometrium, the remaining myometrium becomes too thin to contract effectively and seal the uterine vessels. At term, the placental blood flow is nearly 800 ml per minute. So, when the myometrial thickness is reduced to less than 5 mm, the risk of torrential bleeding becomes extremely high. This is why the placenta accreta spectrum is considered as a life-threatening obstetric condition. Any procedure like DNC, radiation, endometritis, endometrial resection or ablation that causes injury to the endometrium increases the risk of PAS. The risk of accreta spectrum rises with the number of previous cesarean sections. About 4% after 1 LSES and 11% after 2 and 44% after 3 LSES. Let's see what happens with the history of myomectomy. If it is a full scar myomectomy, it carries about 4% risk. But if it is a subserosal myomectomy where the uterine cavity is not entered, it does not increase the risk for accreta spectrum. Presence of twin pregnancies increases the risk of PAS to fourfold higher due to the larger placental surface area and increased trophoblast invasion. Now let's understand why placenta accreta spectrum happens. First, think of the uterus as a soil into which the placenta implants. In PAS, this soil, that is the decidua, is damaged or completely absent, usually because of scarring from previous surgeries. So right from the start, the placenta is attached to an abnormal surface. Because of this, the normal decidual stop signal that tells the trophoblast how deep it can go is lost here. So with no boundary in place, the placenta simply invades more aggressively than normal. There is also a disturbance in the immune microenvironment. Maternal immune cells usually regulate placental invasion, keeping it controlled and balanced. But in past, this balance is disrupted, allowing for deeper and unchecked invasion. Next comes the extracellular matrix and fibrinoid remodeling. Instead of forming a proper separation layer, the scar tissue actually traps the invading trophoblast. This is called lock-in mechanism and it prevents the placenta from detaching at the time of delivery. Finally, there is vascular remodeling failure. The scarred myometrium cannot remodel the spiral artery like it normally would. So, instead of stable and low resistance vessels, we get dilated, fragile and high flow vessels that are very prone to catastrophic bleeding. This creates a unique hemodynamic phenotype of accreta spectrum. When we compare the accreta spectrum with preeclampsia, as you can see in the picture, the contrast is very clear. Preeclampsia is a disease of too little invasion, whereas accreta spectrum is a disease of too much invasion. Both start with abnormal placentation, but the pathways diverge. So in summary, the accreta spectrum develops because of defective decidua, loss of stop signal, immune imbalance, abnormal remodeling, and fragile vasculature, all of which allow the placenta to invade far deeper than it should. There are two early first trimester markers of accreta spectrum. One is caesarean scar pregnancy and the other one is low implantation of pregnancy. When the gestation sac gets implanted in total or partially within the caesarean scar, then it is caesarean scar pregnancy. Also, the gestational sac in such cases may have a teardrop or triangular shape. In the first picture, we can very well make out the teardrop appearance of the gestation sac. Now, what is low implantation of pregnancy? Up to 8 weeks 6 days, any gestation sac located close to the internal cervical os is low implantation. In up to 13 weeks 6 days, placental implantation located posterior to partially filled maternal bladder is also low implantation of pregnancy. Now, having understood what is cesarean scar pregnancy and low implantation pregnancy, let us see in what way it is responsible for increasing the risk of Accreta spectrum. Implantation within the cesarean scar defect allows for early placental invasion leading to utrovesical hypervascularity and even extension of placental tissue beyond the uterus. And this pattern can greatly increase the chance that the patient will require hysterectomy later in pregnancy. Low implantation of pregnancy is seen in 28% of Accreta cases in late first trimester. As the uterine grows, the sac appears to move fundally, but however, the placenta remains anchored to the scar. This is especially common when the placenta is anterior under the scar. So, cesarean scar pregnancy and low implantation of the pregnancy should warn us to monitor these pregnancy for Accreta spectrum. In addition to other first trimester markers we discussed, loss of lateroplacental clear zone is one of the most reliable early signs and strongly suggests abnormal placental invasion. The presence of placental lacunae as well as bladder wall abnormalities also raises concern for deeper invasion. So these features can appear in some cases even in late first trimester. However, presence of these findings should prompt us to have a careful follow-up. In the first picture A, you can see the three arrows pointing towards the normal hypoechoic retroplacental zone. Whereas in the second picture, the three arrows point towards the area where you don't see that normal retroplacental space. So this is called absence of normal retroplacental hypoechoic zone. In first trimester, a structured ultrasound approach is essential for identifying early signs of Accreta spectrum. The area of interest should be magnified so that it occupies at least half of the ultrasound image. Also, we should adjust the focal zone at appropriate depth to get the maximum visualization. Uterus should be evaluated especially in the mid-sagittal plane to document the gestation sac up to 9 weeks and the placental location up to 13 weeks 6 days. When we evaluate the gestation sac or placenta, its relation to bladder, cesarean section scar or internal cervical os should also be documented. In early gestation up to 8 weeks 6 days, we should not forget to evaluate the shape of the gestation sac also. Color Doppler should be used with low velocity scale and low wall filter and also high gain to detect subtle vascular flow while keeping exposure to embryo as limited as possible. Now let's move on to second trimester ultrasound findings in Accreta spectrum. This table gives us the list of unified descriptors recommended internationally by the European Working Group for Abnormally Invasive Placenta, so that all of us can describe PAS findings in same clear, consistent way, whether in routine practice or in research. The descriptors are divided into two major categories. One is 2D grayscale markers, such as loss of clear zone, abnormal placental lacunae, bladder wall interruption, myometrial thinning, placental bulge and focal exophatic mass. And the second one is color Doppler markers, which is nothing but utrovesical or subplacental hypervascularity, presence of bridging vessels, and lacunae failure vessels, and intraplacental hypervascularity on 3D Doppler. Each of these findings reflect a different aspect of abnormal placental invasion, and in the upcoming slides, we will see each descriptors separately along with the ultrasound images. Now let us first see 2D grayscale markers for Placenta Accreta spectrum one by one. In this slide, we are going to look at the retroplacental hypoechoic zone, also known as retroplacental clear zone. Normally, we should see a thin echolucent space between the placenta and the endometrium. This plane represents residual glands and vascular plexus. When this layer is intact, it appears as a continuous hypoechoic line on grayscale imaging, and you can see that it is highlighted with the yellow color in the image. In presence of Accreta spectrum, this clear zone becomes lost or irregular. Absence of this hypoechoic plane suggests deficiency in Itabush layer, and which is a direct marker for Accreta placenta. However, the specificity of this finding is controversial because there can be potentially false positives because of the artificial compression produced by the probe pressure, leading to the disappearance of this clear zone. So this emphasizes that we should not use excessive probe pressure, especially when we need to evaluate this clear zone in suspicion of Accreta spectrum. As the gestation age advances, the visibility of this clear zone actually improves because of increased uteroplacental flow and also due to myometrial thinning. Now let's see the pathophysiology behind the placental lacunae. In cases of placenta accreta, the absence of normal decidual layer and spiral artery leads to marked thinning of the myometrium, with the remaining myometrial thickness often measuring less than 2 mm. Consequently, when the placenta develops over an area of marked myometrial thinning, the basal plate of one or more lobules will get to lie very close to large arterial circulation at the uterine periphery. As a result, the intervillar space of those lobules becomes directly supplied by radial or arcuate arteries instead of spiral arteries as in normal lobule. In any normal placental lobule, after physiological transformation, the blood flow entering the intervillar space through spiral artery has very low velocity, approximately around 0.5 to 1 cm per second. Whereas, in the case of accreta lobule, which is close to arcuate or radial arteries, the peak systolic velocity of the blood flow entering the such accreta lobule can be close to 30 cm per second. These high-velocity feeder flows distort the architecture of one or more lobules, including disruption of the interlobular septa. This altered hemodynamic environment interferes with normal venous drainage also, leading to secondary formation of placental lacunae. In this slide, we can see a classic ultrasound image demonstrating multiple placental lacunae, giving the placenta a very typical moth-eaten appearance or Swiss cheese pattern appearance. The labels help us orient us. AC is amniotic cavity, B corresponds to maternal bladder, and P indicates the placenta. The lambda sign symbols the individual lacunae. Here we can clearly see large irregular sonolucent intraplacental spaces, which are characteristics of Accreta spectrum, and they are visible on both transabdominal and transvaginal grayscale imaging. If you observe, these lacunae are all close to the basal plate or the myometrium, and we should remember that maternal position or uterine contraction or any direct pressure due to the ultrasound probe will not cause any major change in the shape or number of this lacunae. The turbulent flow within the placenta lacunae is often visible in the grayscale imaging. Finberg's grading scale classifies lacuna based on the number and extent. Grade 0 means no lacunae, grade 1 plus is 1 to 3 small lacunae, grade 2 plus is 4 to 6 larger lacunae, and grade 3 plus is more than 6 or diffuse lacunae throughout the placenta. This last grade of 3 plus is most strongly associated with Accreta spectrum. According to standardized ultrasound descriptors, the definition of abnormal placental lacunae is presence of numerous lacunae, including some that are large and irregular, according to Finberg grade 3, often containing turbulent flow visible on grayscale imaging. The next finding is bladder interruption. If you see the first image on the left side, you can observe that there is one hyperechogenic band or line between the uterine serosa and the bladder lumen. Normally, this line has to be smooth without any interruptions. On the top right side image, you can clearly see that this smooth line is interrupted and there is distinct break in the continuity of the hyperechoic band. In the right lower image, instead of straight uniform line, the bladder wall becomes wavy, irregular and uneven. So this all corresponds to abnormal adherence or invasion at the utrovesical interface. The next ultrasound parameter that we are going to see is myometrial thinning, which is nothing but thinning of myometrium overlying the placenta to less than 1 millimeter, or if it is undetectable, then it is also called myometrial thinning. In the picture on the left upper corner, you can see the normal position of the myometrium and the thickness where it can be easily measured. If you look at the image in the center, the same normal myometrium has been magnified here. The bright hyperechogenic line above represents the normal bladder wall, which I have highlighted, and the double headed arrow just beneath it shows the measurable thickness of the underlying myometrium. If you see the picture on the right side where it's labeled as myometrium undetectable, you can see that there is hardly any measurable myometrium that is seen, and also that hyperechogenic bladder wall is also interrupted, and this can be clearly seen in the picture. The thinning of the myometrium happens because trophoblastic invasion replaces the normal myometrial tissue, and when this thinning occurs, the placenta sits directly over the underlying serosa, increasing the risk of major hemorrhage. Next ultrasound marker is nothing but placental bulge. As we have seen already, not only the hyperechogenic bladder wall, but also the uterine serosa follows a smooth and uninterrupted contour as seen in the picture on the left. Whereas if you see the image on the right side, you can see that the serosal outline is no more smooth and it is seen clearly deviating from the expected plane with outward bulging of the placental tissue towards the bladder. This outward contour change occurs because the residual myometrium is extremely thin or absent, leaving the uterus unable to maintain its structural integrity. The serosa may still look intact, but overall shape is clearly distorted. So a placental bulge essentially represents outpouching of uterus at the site of invasion, and when present, it suggests that there is insufficient myometrial thickness to contract and provide living ligature, highlighting the higher risk of the Accreta spectrum. So the next ultrasound marker is nothing but focal exophytic mass. The image on the left side is an example for normal uterine contour. Now let's look at the image on the right side and put together everything we have learned so far. First, notice that the smooth hyperechogenic bladder uterine serosal line is interrupted, which is bladder wall interruption sign. Next, the myometrium is almost immeasurable, which further raises the suspicion of PAS. And the third marker that we saw was placental bulge, and here it is clearly evident where the uterine contour is distorted outwards. In addition to all this, this case also demonstrates a focal exophytic mass. If you look at the magnified image below, you can see the placental tissue breaking through the uterine wall and extending beyond it, projecting towards the filled uterine bladder. Now let's move on to color Doppler markers. Now we are moving on to color Doppler markers. Out of that, the first one is utrovesical hypervascularity. On the left side, you can see a normal comparative example where there is only minimal scattered flow between myometrium and the posterior bladder wall. Whereas in the image on the right, you can see a striking amount of color Doppler activity at the utrovesical interface. Why this occurs is because it is filled with numerous tortuous and densely packed neovessels. If you keenly observe the color flow signals, you can notice that it is multi-directional flow pattern and showing aliasing artifact reflecting a turbulent and high velocity flow. The next color Doppler marker is subplacental hypervascularity. Here also you can see a striking amount of color Doppler signal in the placental bed. And the flow in the vessel is turbulent and multi-directional flow with aliasing, representing numerous and tortuous vessels. The next and most important finding is bridging vessels on color flow Doppler. These bridging vessels run in perpendicular direction. These vessels appear to extend from the placenta, crossing through the myometrium, projecting beyond the uterine serosa and extending into bladder or other organs. On grayscale imaging, the same bridging vessels are visualized as parallel tubular structures, often called railroad track sign or equal to sign. The next ultrasound marker is placental lacunae feeding vessels. The placental lacunae feeder vessels are nothing but the vessels with high velocity blood flow from the myometrium into the placental lacunae, causing turbulence upon entry. The next marker is nothing but 3D power Doppler imaging, demonstrating the intraplacental hypervascularity. Both the lateral and the basal view reveals complex irregular arrangement of numerous placental vessels showing tortuous courses and of varying calibers. This abnormal and tangled vascular pattern is another hallmark of deep placental invasion. Now, so far we saw the ultrasound descriptors of abnormally invasive placenta. Before moving on to the next slide, let us see a few practical points to remember. Make sure that the uterine bladder is filled to the extent that lower uterine segment and utrovesical interface can be well visualized. Both transabdominal scan and transvaginal scan can give excellent results. Remember, most of the ultrasound markers of Accreta spectrum appear more commonly in the third trimester. So far, we have gone through several ultrasound markers suggested by EW AIP Group. So this is the international recommendation to standardize how we describe Accreta spectrum findings on ultrasound. But the real question is, what do these markers actually indicate? What exactly are we looking at on the screen? And what does each sign tell us about the underlying pathology? So this study by Dr. Kali helps us to correlate the ultrasound finding with ultrasound stage of Accreta spectrum and corresponding histopathology. Although I'm not going into deeper details regarding the FIGO grading, because it is a clinical grading system, and as we are imaging specialists, let us confine to the ultrasound stage of Accreta spectrum along with the finding and its correlation with the histopathology. When you see placenta previa with no other ultrasound markers, or when you see placenta previa with just placenta lacunae, whereas there is no loss of clear zone or there is no bladder wall interruption, then we stage it as Accreta spectrum stage 0, which means there is only placenta previa and there is no evidence of Accreta spectrum. Now, if you see placenta previa in addition to at least two of the following three ultrasound findings, like presence of placental lacunae or loss of clear zone or bladder wall interruption, then it comes under the stage of PAS1, which means that it could be possibly Accreta or Increta. In addition to all the findings in Accreta spectrum stage 1, if you have utrovesical hypervascularity, then it becomes stage 2, and we should think of possibility of focal Percreta or diffuse Percreta. Now, either Accreta spectrum stage 1 or Accreta spectrum stage 2 with evidence of increased vascularity in the inferior part of lower uterine segment extending into parametrial region is suggestive of Accreta spectrum stage 3, which means that there is a possibility of Percreta invading the inferior third of lower uterine segment and the lateral parametrium. This is the result of meta-analysis by Dr. Antonio. All the ultrasound markers are highly specific for diagnosis of Accreta spectrum, and among that, the discontinuity of uterine bladder interface is close to 100% specific. In addition to the 11 established signs, 8 new ultrasound signs at mid-gestation also were suggested as high risk for Accreta spectrum in various studies. If you want to know further about this newer signs, you can go through the article suggested in the slide. This slide summarizes the Delphi consensus published in 2023 regarding ultrasound signs of Accreta spectrum. The objective of the study was to bring international experts together and decide which ultrasound markers should be standardized for Accreta spectrum evaluation. The authors carried out a systematic review and then followed a 3-round modified Delphi process. A group of 9 experts coordinated the study, and 31 Accreta spectrum ultrasound specialists were invited, out of which 30 completed all 3 rounds. Consensus was defined as more than 70% agreement. Now let's move on to the result one by one. To answer the question of when to perform detailed ultrasound evaluation to rule out Accreta spectrum, the consensus was that equal to or more than one history of prior cesarean delivery, or history of prior myomectomy, or history of prior Accreta spectrum were all the indicators to do the detailed Accreta spectrum evaluation. Now coming to the second part of the Delphi consensus, what exactly did the experts agree upon regarding the ultrasound markers? Out of 11 standardized EWAAP scenes, 7 of them reached clear consensus as reliable markers of Accreta spectrum. They include loss of clear zone, myometrial thinning, bladder wall interruption, placental bulge, utrovesical hypervascularity, placental lacunae, and the bridging vessels. Next, the Delphi panel also reviewed 8 new or emerging ultrasound signs that have been described in the literature. However, none of these newer signs reached the consensus, meaning they are not yet considered as reliable enough for routine practice. The experts also identified 2 additional features that, although not specific, significantly increase the probability of Accreta spectrum. These are the anterior placenta previa and placenta previa with cervical involvement. So if these features are present, our suspicion of Accreta spectrum should be higher. Finally, the panel reached consensus on which signs predict a difficult surgery or higher chance of adverse outcome. These include loss of clear zone, bladder wall interruption, presence of placental lacunae, and placenta previa involving the cervix. So these markers not only help in the diagnosis but also help the surgical team in planning and anticipating the complexity. Now coming to the question of quantification, among all the ultrasound signs of Accreta spectrum, which one should we actually measure or score? This is another important part of Delphi process. 37 experts were asked whether each sign needs a quantitative assessment, and as you can see in this table, the agreement varied widely for different markers. Interestingly, the consensus was reached only for one sign, that is placental lacunae score. I think we have described about the Finberg's grading of lacunae in the early slides. You can go through that. This means that there is no need for quantifying the rest of the markers, and it is enough if they are described qualitatively. So to summarize the Delphi consensus, transvaginal scan remains central for evaluating placenta position and cervical anatomy. The standardized ultrasound markers we discussed are the mainstay of Accreta spectrum diagnosis, and these are the ones we rely on in daily practice. Newer signs do exist, but as of now they are not reliable enough for routine use. So our focus should stay on validated and standardized signs. Now in this slide, let us see the key points regarding the Accreta spectrum based on FIGO guidelines and ACOG and Society of Maternal-Fetal Medicine guidelines. Ultrasound is the first line method for diagnosis of Accreta spectrum. However, absence of ultrasound does not rule out Accreta spectrum. So in high risk women, clinical risk factors are just as important as the imaging findings. MRI is not recommended as initial method of evaluation, but it can be useful in selected situations like when we want to assess the pelvic extension of Percreta or when any area is difficult to visualize adequately on ultrasound. Women diagnosed with cesarean scar pregnancy in first trimester should be clearly counseled about the high risk of hysterectomy later due to Accreta spectrum. A history of one or more previous cesarean deliveries require careful assessment of placental implantation site, especially if placenta is anterior, low-lying, or if it is placenta previa. Finally, all ultrasound signs used for diagnosing Accreta spectrum should be described using standardized protocols, and their interpretation should be consistent with agreed upon definitions. Now this slide shows the proforma for ultrasound reporting in suspected abnormally invasive placenta by the AIP Expert Group. This format helps us standardize how we report Accreta spectrum markers, beginning with patient's demographics, clinical risk factors, placental location, and then systematically covering each and every grayscale and important Doppler signs. This is a freely available article, and I would strongly encourage all of you to download it and keep it handy. It really helps in making our reporting consistent, comparable, and much more objective, and it also greatly improves our communication with the obstetric and surgical teams. So this checklist ensures that no important Accreta sign is missed during our systematic evaluation. Thank you so much for watching. If you like this video, please subscribe and share to your friends.